Thank you. Okay. Okay, so we'll start with arrhythmias. So there are two types of arrhythmias, the ones that are occurring above the ventricles and the ones that are occurring in the ventricles. And if we're talking about based on the heart rate, then it's either bradycardia or tachycardia. And arrhythmia is just abnormality in the cardiac rhythm. So like in this picture, we can see that a normal heartbeat would look like this on an ECG. Tachycardia would be looking at, like, you'd see more QRS, PQRST complexes. And with a slower heartbeat, you'll see few of them. And with irregular heartbeat, there would just be weird looking complexes. So arrhythmia is caused by abnormal impulse initiation, where the SA node is like there's abnormal automaticity of the SA node. It's either slow or it's either fast. When it's slow, it causes sinus bradycardia, and when it's faster, then it's sinus tachycardia. Then abnormal impulse conduction, where these abnormal conduction from maybe the AV node to, the SI node to the AV node, or it can be both, where the initiation is abnormal and even the conduction is abnormal. So classes of antiarrhythmic drugs, there are four main classes, where class one drugs are sodium channel blockers, class 2 are beta blockers, class 3 are calcium channel blockers, and class 4 are class 3 is potassium channel blockers, and class 4 is calcium channel blockers. So we'll start with the first one, which is supraventricular arrhythmias, where the arrhythmia is above the ventricles, and the first one is sinus bradycardia. So in this one, it's bradycardia. So that means that the SA node is not, like, the initiation of the SA node is slower than usual, and it's mostly 60 beats, lower than 60 beats per minute. And like we said yesterday, that normal, was it yesterday or when we were talking about physiology, that normal heart rate would be 60, between 60 and 100. So if it's below 60, then it's bradycardia. Yeah, so the ECG would look something like this with fewer complexes. So etiology for sinus bradycardia, I think the most one that we would talk about would be electrolyte abnormalities with hypokalemia and hyperkalemia, and the others would be like myocardial ischemia and hypothyroidism, of course, any autoimmune disease like SLE, or even hypothermia. Some of the drugs that lower your heart rate would also cause sinus bradycardia, and these are some of the drugs. Then if there is like a fibrotic tissue in your SA node, then that would also result in abnormal initiation or automaticity of the SA node, leading to bradycardia. And signs and symptoms, again, it's the same that we've seen in other heart diseases. Diagnosis, of course, the main one would be the ECG, where it shows this kind of ECG, where it's fewer these complexes, and when you measure heart rate, of course, it's lower than 60 beats per minute. Okay, so since we know the cause of this, what would be how would you treat such a disease? Only one treatment? Okay, fine. So, treatment now would be to increase the heart rate. So the mainstay, that's for like your acute treatment would be giving atropine because we know atropine increases heart rate. But if the patient is hemodynamically unstable, then you give medications like dopamine and epinephrine. Yeah. And for non-pharmacological, and that would be implantation of like a or getting like a permanent pacemaker because we know that it's the SI node that's not uh working properly. So these pacemakers, they like give you the right initiation. Yeah. So that's just for sinus bradycardia. Any questions?
No.
Okay. Then the next one would be the AV nodal block, where it's classified with first degree, second degree, and third degree. So in so now the in the previous one we saw it was the SA node, but in AV nodal is just that um like there's no after the AV node there is no like any conduction or impulses. So with first degree AV block is just that the PR interval, or that's between the SA node and the AV node, it's slower. So you expect your PR interval to be longer. Then in second degree, like whatever is initiated by the SA node is not conducted by the AV node. And the third degree block would be like a complete heart block where uh, none of the impulses generated by the SA node are conducted through the AV node, because AV node is the one now that sends impulses to the ventricles through the Purkinje fibers. So that's third degree block. So first degree is just prolongation of the PR interval. Second degree is just that not all the impulses are conducted by the AV node, and third degree block is there's no impulses there are no impulses conducted through the AV node like at all. So like over here you can see for third degree block, there'll be no association between the atria and the ventricles. They either contract, the atria would be contracted while the ventricles are also contracted. So there's no like association, because we know that the atria have to contract first and then the ventricles have to contract. So the block is either with no SA node, like there's no conduction from the SA node to the AV node, or the block is either from AV node to the Purkinje fibers, no conduction from there. Same etiology, same medications that cause symptoms. Usually for first AV block, patients are usually asymptomatic. Second degree would just cause some like bradycardia, and with third degree AV block, which is complete heart block, now that's when the patient these like severe bradycardia, and the patient experiences like dizziness, lightheadedness, chest pain, fatigue, and all those. Diagnosis again the same with the ECG. So over here, treatment is the same as what we saw in sinus bradycardia, because again, we have to increase the heart rate. Mostly atropine is given, but then if the patient is hemodynamically unstable, then you give epinephrine and dopamine. And of course, for long term, you implantation of a permanent pacemaker. Yeah, so that is for AV block. Any questions? Any clarification, addition?
No question, Hiram, but when you say like the ventricles contract alone and the atrium contract alone, so which means like the impulses that are generated from the AV node, like even if it's the first degree block, it won't be synchronized to the rest of the myocardium,
Yeah,
right?
yeah. So even if it's first degree, it will just be like a slower, but then like when we're talking about third degree, there's no association at all. At least in first degree, there would be some association, but it's just that it's slower contraction. Yeah. So the patient experiences all these symptoms because blood is not being pumped out at the right time, or the right amount is not being pumped to the rest of the body. So the patient gets all these symptoms. Yeah. So sinus bradycardia and AV nodal block, same medication, same treatment is used. Usually for first degree AV nodal block, treatment is not really needed because these patients are usually like asymptomatic. You usually give atropine because you want to increase your heart rate. And if the patient is hemodynamically unstable, then you give dopamine or epinephrine. So the next one is arterial fibrillation, where now there's at least in AV nodal and sinus bradycardia, there was it was like organized, like we saw with this. It's just that it's slower. But in arterial fibrillation, it's just disorganized arterial activation. So there's a loss of contribution of synchronized arterial contraction, and it's one of the most common arrhythmias. Etiologies, again, the same ones that we've seen previously, with other ones like rheumatic heart disease of the heart valves, where the valves are now dysfunctional, so they don't close or open properly. Drugs, again, some of the same ones. So like over here, we can see arterial fibrillation. There's just no correlation. You can see from between this one and this one, it's longer, then it's smaller. It's not synchronized. It's just it's disorganized. So sometimes this atrial fibrillation is triggered by electrical impulses generated within the pulmonary veins. So it's chaotic, disorganized atrial activity. So the depolarizations are not complete, the contraction is not complete, or even the relaxation is not complete. Therefore, pumping the blood out is not adequate. Yeah. So yeah, if there is structural abnormalities of the atria, like fibrosis, dilation, hypertrophy atrial fibrillation can occur because these affect now the SA node or the AV node. And of course, like if there is oxidative stress also. Yeah, and then also, since we know that blood is not being pumped out, you expect some of the blood to just stay back in the heart, which causes now a thrombus formation, which can now, if it does travel, it can travel to the brain, causing an ischemic stroke, or it can travel to other parts of the body, causing either pulmonary thromboembolism or venous embolism. Yeah, so there are 4 types of atrial fibrillation, where the first one, paroxysmal, is it terminates within 7 days of onset. Persistent, it lasts longer than 7 days. Long-standing is continuous within 12 months or longer, and permanent cardioversion, it still doesn't terminate. You guys can hear me?
Yeah.
Yes.
Okay. So classification again, paroxysmal, where it terminates within 7 days of onset. Persistent, where it lasts longer than 7 days. Long-standing, it's continuous within 12 months or longer, and permanent, even with treatment, it does not terminate. Clinical presentations. Now over here, it's where the heart is beating quite fast. So yeah, and then the same presentations, like with chest pain, dizziness, shortness of breath. ECG would show that there is absence of P waves, and it's chaotic arterial electrical activity. And the ventricular rate is usually 120 to 180 beats per minute. So therapy, what would you guys think would be the therapy for atrial fibrillation?
Okay. I think one of the therapies that you can do is you prevent the risk of forming stroke, like ischemic stroke, or the systemic thromboembolism.
Yes. So you give like this anticoagulants because we know that there's a risk of an emboli forming. Anything else? Okay, so for atrial fibrillation, If it's less than 48 hours of onset, then you consider a DCC, which is a direct cardio conversion. Yeah. And if that is not successful, then you now give the drug. So if the patient has heart failure with preserved ejection with no preserved ejection fraction, then you give these drugs. And with preserved ejection fraction, then you consider these 3 drugs. However, if it's more than 48 hours, then you don't do the conversion. You go straight to giving anticoagulants like warfarin or rivoxaban, or you can do this transesophageal echocardiogram to see whether there's any thrombus that was formed. Yeah, and then if there is no any thrombus, then you consider the DCC, because we can't do a DCC when there is a thrombus in the vessel or in the blood, because when you're giving this DCC, which is this, it's a procedure to convert abnormal heart rhythm to normal heart rhythm. So you're kind of giving like a shock or something, so that all the cells of the heart go into normal heart rhythm. But when you have a thrombus in the heart, or you might dislodge it during this procedure, so if it's after 48 hours, then you first have to see if there's a thrombi or not. If there isn't, then you do this procedure. If there is a thrombi, then you consider the anticoagulants like warfarin, and then you have to give it at least for more than 3 weeks before the procedure, and even after the procedure you give it for at least 4 weeks. So that's it for arterial fibrillation. Other medications that you consider, like this digoxin, which is effective to control the ventricular rate, because over here we say that ventricular rate is usually, it reaches for 120 to 180 beats per minute, so we need to lower that down. Yeah, that is for arterial fibrillation. Any clarification, question? Mm-hmm.
I want to add that like for long-term use of digoxin, it's effective for ventricular rates that with the patient who have ventricular rates, like it's effective for ventricular rate in patients at rest. Because it's, if the patient are not at rest, the action of sympathetic nervous system during exercise will stimulate the effects of digoxin on the parasympathetic nervous system.
Yeah, I think that was here. Yeah, so if the patient is undergoing any physical activity, then you consider the beta blockers or the calcium channel blockers. But if the patient is not going through any physical activity, then digoxin would be okay to give. Yeah, and then after all that, for maintenance, again, it's the same medications at lower doses. Anything else? Okay. Okay, so now we move on to ventricular arrhythmias. In the first one, we saw those were supraventricular arrhythmias occurring in the atria. The first one was sinus bradycardia, where the SA node is generating impulses of less than 60 beats per minute. Medication that you give is atropine, dopamine, epinephrine. The second one was AV nodal block, where we saw first, second, and third degree blocks. Again, it was the same treatment as sinus bradycardia, giving dopamine, and for dynamically unstable patients, you give atropine and epinephrine. The third one we saw was atrial fibrillation, where the impulses are chaotic, and some of the drugs that you give over here are beta blockers or digoxin for patients with preserved ejection fraction. And then digoxin can be given when patients are not undergoing any physical activity. But if they are, then you consider beta blockers and calcium channel blockers. Of course, we know that it can cause thromboembolism, so you give warfarin or heparin, or even these oral anticoagulants like rivoxaben. Then we go to the next one, which is now ventricular arrhythmias. The main one would be ventricular tachycardia now, where it's fast heartbeats at a rate of 150 to 250 beats per minute. And even over here, the P wave is usually absent because the QRS complex is quite wide, so it covers the P wave. So in another one that we saw that the P wave was absent was in arterial fibrillation. So over here we can see it does not look anything like the normal QRS complexes. It's just like this. So it can be caused by acute myocardial infarction, cardiomyopathy, digoxin toxicity, or any congenital heart disease. Same clinical manifestations. Over here, you do, of course, the ECG. Then you have the monomorphic ventricular tachycardia, where the shape and the appearance of the QRS complexes are similar throughout. But in polymorphic, the shape and the appearance of the QRS complexes, they vary. So it's the monomorphic ventricular tachycardia that's more common compared to polymorphic. And then for goals of therapy, simple. If it's normal left ventricular function, then you consider this procainamide and amiodarone. But with preserved ejection fraction, then you give this medication. That's it for ventricular tachycardia. You want to lower that heartbeat. For hemodynamically unstable patients, you consider the direct current cardioversion, which now restores all the rhythm for the heart. With hemodynamically stable patients, then you just give the medications, but as IV. Yeah, and then the last one is ventricular fibrillation, where it's one of the most serious ones, and of course the most common cause of cardiac death, caused by the same other diseases like myocardial infarction, drug overdose, cardiomyopathy, anesthesia, or heart trauma. So over here, we're seeing that the complexes are like chaotic, disorganized, and just irregular. There's no any sort of like organization. At least over here, we saw that the QRS complexes, but they're quite like organized, they're similar. But over here, it's just they're just disorganized. So there's absence of ventricular depolarization. So there's no cardiac output, or just lack of pulse or cardiac output or blood pressure, because that blood is not being pumped to the rest of the body, or it's not being pumped to the lungs for oxygenation. Yeah, and then some of the drugs that cause, again, it's the same ones. Over here, it's mostly clinical presentation would be loss of pulse and blood pressure, and the patient usually immediately collapses. Diagnosis, again, the same, using the ECG, where the QRS complexes are, you can't recognize them. Goals of, therapy. You perform CPR. If, of course, they're not at the hospital, and electrical defibrillation if they're in the hospital. And oxygen should also be administered as soon as possible, because if there is no pulse or there is no blood pressure, then that blood is not being pumped to other organs. So oxygen should be given so that it does not cause a lot of damage to your other organs. Yeah, so when you look at the pulse and then you initiate CPR, give oxygen, or you perform defibrillation for 2 times, but that's not enough. So you give epinephrine and vasopressin. Yeah, then you can also give other drugs like this amiodarone. Yeah, so that is it for arrhythmias. Ventricular arrhythmias, you look at ventricular tachycardia and ventricular fibrillation. Ventricular tachycardia, the ventricles are beating quite fast with 150 to 250 beats per minute. The QRS complexes hide the P wave, so in the ECG, it looks like there's no P wave. And these QRS complexes are usually similar in shape, that is monomorphic, but when it's polymorphic, they're usually different, but it's quite rare to see that. For patients with normal left ventricular function, then you give drugs like procainamide and amiodarone, but if it's reduced or preserved ejection fraction, then you give amiodarone. When you talk about ventricular fibrillation, there is just irregular, disorganized, and chaotic electrical activity when you look at it in the ECG. The first thing that you do is perform CPR, give oxygen, and then you can also perform a defibrillation twice. And that's just not enough, so you have to give epinephrine, vasopressin, and even amiodarone. Yeah, so that is it for arrhythmias. Any questions? Okay, then we come back at 10:45 and then we go through venous thromboembolism. What causes venous thromboembolism?
It's a result of clot formation within like the venous circulation.
What else?
So you will see both deep vein thrombosis and pulmonary embolism.
Yeah, those are two of the main causes, whatever that is caused by clot formation. Anything else? Okay, so Mhm.
there was this triad known as Vachav's or Vacus. I don't know how to pronounce that name. Triad that contains three things that can lead to embolism, and that was hypercoagulability, whereby someone is predisposed to clot, for example, due to excessive clotting factors or reduced anti-clotting mechanisms. Then there was stasis, when blood is in stasis for so long, has stayed at one place for a while. So that can also lead to clot because the platelets start to aggregate. And then the third thing was endothelial damage. So when damage or dysfunction, so when there's damage to the blood vessel, so that increases your risk for clots. Yeah.
Yeah, exactly. So for this venous thromboembolism, we're not going to go into this pathophysiology because we already saw it in ischemic heart disease, and although that was with atherosclerosis, over here it's just clot formation. So you have all this actually we need to see that cascade. Let me just find that. Yeah, so the coagulation cascade. We have the intrinsic pathway and then the extrinsic pathway. So for the intrinsic pathway, it usually starts with I think, yeah, that's 12. Yeah. From 12 to 11, then 9 to where 10 is the one that is common for both the pathways. For extrinsic is usually 3 and 7. And yeah, that whole coagulation pathway. So if there is like guys said, hypercoagulability, where some people have this hereditary diseases like deficiency in protein C, S, or antithrombin. Some of them can have even acquired hypercoagulability, where certain drugs like contraceptives or estrogen replacements can increase the clot formation. And then when we're looking at estrogen contraceptives, they usually increase some of these factors like fibrinogen, leading to blood clot, and they also decrease antithrombin 3. So yeah, when we're looking at the coagulation cascade, all this, and then it leads to the formation of this stable fibrin clot. Yeah, so this clot, when it's formed, it's usually caused by blood stasis that we saw previously, that in arrhythmias, that if blood is not being pumped out by the heart, then because of blood stasis, it can lead to an emboli being formed. Vascular injury also, because when your blood vessels are injured, this clot formation happens so that you don't lose blood. And hypercoagulability. So the main is the deep vein thrombosis, DVT, and pulmonary embolism. So here, like we said, blood stasis, vascular injury, hypercoagulability. And some of the other risk factors would now be age, because we know like the older, the elderly, like they don't have a lot of physical activity. So that can also cause like blood stasis in their legs. Drug therapy, like I said, for mostly with estrogen containing drugs. So pathophysiology, again, the same with how the clot is formed. Like over here, you can see. So some of the inhibitors for this coagulation pathway would be heparin and thrombomodulin. Just a minute. Yeah, sorry. Yeah, so thrombomodulin, it usually binds to the thrombin, and it activates protein C. Protein C over here, like we can see protein C and protein S. All these, what they do, they degrade these tissue factors so that this coagulation cascade cannot occur. Then other diseases would be this VWF diseases, where there's high, some patients have this high in their plasma, so platelets can easily bind to your endothelial cells, causing like a platelet plug, and then eventually leading to a clot formation. Yeah. Yeah, here. So just the coagulation cascade. For clinical presentation, you usually look at this Wells criteria. So you have to see, like for DVT, you score them according to like what they have, and then the higher the score, the higher they are at risk. And then for DVT, it's usually like that's mostly in the leg. So if like swelling, pain, warmth, and skin discoloration that we can see in this picture over here. Lab tests over here now, that's when you do this prothrombin and activated partial thromboplastin time, which now because coagulation is, yeah, you just basically do them. And then when you do the D-dimer test, you look at, this is just a byproduct of thrombin generation. So if somebody has a clot, this D-dimer would be quite high. And some patients also have elevated ESR, and white blood cell count is high also. The duplex ultrasonography is the mainstay for diagnosing DVT, and it detects the direction of blood flow in the legs. But the disadvantage for this is that it cannot detect small blood clots in like your distal veins. Sorry, it's this venography that is the gold standard, where a contrast dye is injected into the foot vein, and it shows if there's any blockage or what. Yeah, so like I said, you look at the Wells score. So when you suspect DVT, and you do the Wells score, and then if there is D-dimer is positive, then you have DVT, and yeah, just mostly that you have to look at the Wells score and D-dimer to either rule out or to say that there is DVT in this patient. When looking at clinical presentation for pulmonary embolism, now you'll have pulmonary symptoms like cough, chest pain, wheezing, and yeah, all that. Tachypnea, sweating, and some like there's increased jugular venous pressure. Again, for pulmonary embolism, there is this Wells score, and diagnosis would be the same also with D-dimer, and you can also do a CT scan of the lungs. And pulmonary angiography is now the mainstay, where again you inject a contrast dye into the pulmonary artery to see where it has where the blockage is. Again, doing the same thing, looking at the Wells score and D-dimer to rule out or to say that there is pulmonary embolism. Yeah, so these pulmonary embolism or venous or DVT is usually common in hospitalized patients or patients that have undergone any surgery. So like prophylaxis with medications or ambulation would be like to prevent any clot formation. So risk factors for venous thromboembolism in hospitalized patients. Again, there's this prediction scoring that is done. Yeah, okay. So now that we know that what is caused, what would be the therapy?
Pardon, Hiran?
What would be the therapy for DVT or pulmonary embolism? Since we know what has been caused, what causes DVT or PE?
Okay, in this case, there is the from the slides that you're currently displaying, there is walking, which will increase venous blood flow and will promote flowing of the natural antithrombotic factors. Okay, though in this walking majorly, we are looking at people who are maybe long flights or their work involves a lot of sitting. You'd encourage them to walk a bit. You know, they stand up perhaps every 30 minutes and walk a bit. Then now, when we come to the pharmacologic therapy, we'll have the anticoagulants. Acutely, we'll have something like heparin to break down the clot, but then we can give with warfarin to prevent as a secondary prevention for future clots. Yeah.
Yes. One question, why is heparin and warfarin given together?
Because warfarin has that delayed onset of action, because the mechanism of action involves inhibition of synthesis of vitamin K dependent factors. So it has no effect on the circulating, already in circulation of the vitamin K dependent factors. So it has a delayed onset of action. It may take up to 4 days for it to kick in. And even before the 4 days, warfarin may actually cause some hypercoagulability. So you have to give it to the heparin.
Yes, exactly. So since heparin is a fast acting, yeah, okay, sorry. Go on.
Trying to add on what Gas has said, maybe he said heparin for, I think heparin will prevent any clot formation, and thrombolytics are the ones which are going to lyse any clots that have been formed.
Yes. I think what Chai is saying is heparin is given before warfarin, not only because the delayed onset of warfarin, because there is already circulating coagulants that are already in the system. So the heparin will act in dissociating those coagulants that are already in circulation. There's even a lab test that's done to detect heparin antibodies. Yeah.
Yeah, that's true. Anybody else? What else? Which other drugs can be given? Okay, so like guys said, ambulation is one of the non-pharmacological therapy because it increases the blood flow in the legs. So that's what we need, because if there's no blood flow, then there's blood stasis, and that causes the clot formation. There's so many medications that can be given for prevention would be low molecular weight heparins, this unfractionated heparins, but these are just for prevention when you know that the patient is like, mostly for hospitalized patients where they're either going into surgery where blood clots can form, or there's not enough physical activity with the patient when they're hospitalized. And also, of course, this oral anticoagulants like rivaroxaban and apixaban. So for duration of prophylaxis is usually given mostly up to 35 days, because there is still risk of venous thromboembolism even like 1 month post-surgery. Okay, so for therapy, there's acute, long-term, and extended phase. For acute phase, it's usually 5 to 10 days, with long-term the first 3 months, and extended is beyond 3 months. So for acute, you usually give the fast acting drugs like the low molecular weight heparins. For long-term treatment and extended treatment, you give warfarin or direct acting anticoagulants. Yeah, so the first one would be thromboembolitics, where they restore the venous the venous patency more quickly, and but these medications are usually not really used because of failed therapies. Yeah, and if they do have to give, then some of the medications are like streptokinase, urokinase, and alteplase. Then you have the unfractionated heparin, but what this does, it will not dissolve the clot, but rather just prevent its growth. And that's the same with thromboembolytics. They will not dissolve the clot, but that's what we want. That we want to dissolve the clot, but yet you can still give them so that the clot doesn't keep growing bigger. So when you're giving this, you usually measure this APTT. It's usually like you monitor how the patient is responding to the medication using this test. I think we'll see like all this what they do in pharmacology. Yeah, and it's usually given as IV or subcutaneous injections, and not intramuscular, because absorption is quite erratic. Some of the adverse effects would be bleeding, of course, with any of these medications. When you want to dissolve a clot, you're inhibiting now the coagulation pathway, so bleeding would be a major symptom. So in case you do get like major bleeding occurs, then protamine sulfate is given, so that's like an antidote to these medications. With unfractionated heparin, you have 2 types of thrombocytopenia. Type 1, which usually occurs within the first 2 days of treatment, and it's a non-immune disorder, while type 2 it's more serious and it's immune mediated, and it usually occurs between 4 to 10 days after exposure to heparin, but it's less common. So the common one is type 1, where platelet count is below that. Yeah, like Fatma said, this heparin antibodies, to detect this heparin antibodies must be performed to confirm the diagnosis of this heparin-induced thrombocytopenia. So in case that the patient has this thrombocytopenia, you stop the heparin and you would give other medications like this direct thrombin inhibitors, that they don't there's no cross sensitivity or cross reactivity between that. So they will not produce the heparin antibodies. Then they also cause hypersensitivity reactions, hyperkalemia, and also osteoporosis. Then the low molecular weight heparins, which are the fast-acting ones, and they're usually given in the acute phase. And yeah, so some of the examples would be enoxaparin, which is, I think, one of the most common ones. And yeah, the other two also. For these drugs, the prothrombin time is usually not really affected. So that's a good thing, but you need to look at the PT and INR, like the baseline, before you initiate therapy. Again, major bleeding can occur, so you give protamine sulfate. And then this is fondaparinux, which is an inhibitor of factor 10. And yeah, it binds to antithrombin. It can be given both for DVT and pulmonary embolism. Then the direct thrombin inhibitors, they don't have that thrombocytopenia as a side effect. So in case the patient was given the unfractionated heparin and they get that side effect of thrombocytopenia, then you can switch to direct thrombin inhibitors. So yeah, then also the direct oral anticoagulants like apixaban and rivaroxaban. Then of course warfarin, but it's not given as monotherapy, like we said. Why it's not given? Because of the delayed onset of action. Then some of the like if the patient is a slow metabolizer, then that onset of action is delayed more. What warfarin does, it inhibits vitamin K reductase, so those factors will not be produced. Then of course, with all these medications, before you start therapy, you have to measure baseline PTINR and CBC also. Then if you want to check how the patient is responding, you keep on doing these tests either weekly or every 2 weeks to see the progress of that clot, if it has been dissolved or if it's still there. Side effects for warfarin: bleeding, of course, but the other effects would be the non-hemorrhagic ones, where it causes skin necrosis and the purple toe syndrome. It's teratogenic, so it's not given during pregnancy. And the antidote for warfarin is vitamin K, because it's inhibiting vitamin K reductase. So if you increase vitamin K, it reduces the effects of warfarin. Yeah. Again, duration, like I said, it has to be for that long term, which is for the first 3 months, and then for extended period, which is more than 3 to 6 months, to prevent any clot formation or to dissolve that clot. So like over here, it says at least for 6 to 12 months. Yeah, so those are a lot of drugs given, or you can choose from to be given to patients with VTE. Yeah, any question?
Also, the reason why we also avoid giving warfarin as the initial first therapy is since it blocks vitamin K reductase, so it will inhibit all the coagulating factors like protein C, it will be inhibited. So the reduction of these natural anticoagulants before the clotting factors is depleted, it will lead to hypercoagulable state of warfarin therapy.
Yeah, exactly. That's whatever you said on this slide. Anything else to be added? Any questions, clarification? Okay.
Hiral,
Yeah.
can you repeat the warfarin heparin thing?
Okay, so heparin and warfarin are usually given together because warfarin has a delayed onset of action because it doesn't inhibit the clotting factors directly. It inhibits them indirectly by inhibiting vitamin K reductase. What vitamin K reductase what it does is that we need vitamin K for those clotting factors to be produced. So if there is no vitamin K reductase, then there'll be no clotting factors. But that's delayed because it doesn't act on the circulating clotting factors. So you give this heparin that acts directly on the clotting factors. So heparin is usually given for at least 5 days, and then I think it's discontinued, and warfarin is given continuously. And also because these clotting factors have a longer half-life, so even if you're giving warfarin itself, then it's not going to work on those clotting factors that are already circulating.
Okay, thank you.
Welcome. Any other question? Otherwise, we take 5-minute break and then we finish with shock, which is, I think it's a small topic, so we'll finish early.
I think shock is when your systolic blood pressure has fallen below 90 or your diastolic blood pressure has fallen below 60. Then we'd say this person is in shock.
Yeah, exactly. Anyone else? Black Panther has said when blood volume is low, that's also true. What else? Okay, so yeah, it's when there's no enough blood flow to your other, like to all your organs, and since there's low blood flow or blood volume, there'll be less oxygen delivery to those organs. And like Gaia said, when BP has gone below 90/40. So there are 4 types of shock. There's hypovolemic, where there's inadequate volume of blood. Distributive, where there's increase in vascular system because of vasodilation. Cardiogenic, when there's inadequate heart output because of myocardial abnormalities. And obstructive, again with inadequate cardiac output, but because there's obstruction of blood flow in the lungs or in the heart. So when you look at the differences for hypovolemic and cardiogenic, it's the same, where some of the signs would be cool extremities, while in distributive, because distributive is still vasodilation, so there'll be warm extremities. Then for cardiogenic shock, it can be cause of myocardial infarction, dilated cardiomyopathy, or the arrhythmias. Then you have mechanical cardiogenic shock and obstructive cause, like for pulmonary embolism. For distributive, it can either be septic shock or because of anaphylaxis. And like I said, because of the vasodilation, the skin is usually warmer compared to the other types of shock where it's cool. So hypovolemic, it can be hemorrhagic and non-hemorrhagic. Hemorrhagic because of trauma or a GI bleed or ruptured aneurysm. Non-hemorrhagic shock because of dehydration, either from diarrhea, vomiting, burns, or third spacing of volume. Third spacing of volume is when that plasma or that fluid moves into between your blood vessel and your cells, so in the interstitial space. For pathophysiology, yeah, it's just those main causes that causes like either blood loss or just that. So like I said, that there's decreased oxygen delivery and nutrients to those to those organs. So that means lactic acid will be produced. So since it's oxygen is not delivered to so many organs, you'll have so many clinical manifestations with the heart, brain, the liver, lungs, kidney, with the GI tract, and of course even hematologic with thrombocytopenia and coagulopathies. Symptoms usually thirst, weakness, lightheadedness, and also pressure is low, tachycardia, hypothermia. The skin color depends on which kind of shock it is. With distributive, it would be like it won't look pale, but then with the other types of shock, because the extremities are cool, then it will be like pale looking. Laboratory, for diagnosis, you look at serum lactate, because since there's no oxygen delivery, lactic acidosis or lactate formation increases. There'll be decrease in arterial pH because of this acidosis, hypernatremia, decreased HB, elevated BU, and even hyperglycemia, because there is less blood volume. So whatever electrolytes or proteins or whatever, all this glucose that you have in the cell, in the plasma, it's more concentrated. So you see hypernatremia, hyperglycemia, elevated serum creatinine. So since we know, what would be the therapy? What would be managed? How do you manage shock?
Yeah, I think in this case we'd give first, the most important thing would be fluids. Then also some vasopressors, things like norepinephrine for the vasoconstrictive action, then oxygen.
Yeah, and what else? Anybody else?
Okay, so I think according to the pathophysiology of hypovolemia, when there is decreased cardiac output, like the body tried to compensate and it cannot compensate for that by activating the sympathetic nervous system. So it will release ADH and all those aldosterone. It won't help, right? So when those catecholamines and fluid retention occurs, the delivery of oxygen to the tissues is decreased. So lactic acid is formed as a byproduct. So we can decrease lactic acidosis and then decrease tissue perforations. Yeah. Also, there is isotonic solution that I don't remember the name, but it's like it contains both the sodium chloride ions and the Ringer solution. It's used to
Yeah, that's
to
the
decrease
Ringer's
the
lactate.
metabolic acidosis. Huh?
That's the Ringer's lactate.
Yeah, but I don't know. The fluid therapy, it works by decreasing the metabolic acidosis that was led by the compensatory mechanism. Yeah. And then you can also use exogenous, like molecular weight exogenous plasma polymers. I don't know how they function, but I think they reduce the fluid overload. I'm not sure about that. Yeah.
Okay. So since we know that there's less blood volume, so the first thing you would give is now these solutions to increase your blood flow, to increase your blood volume. So the first one would be crystalloids, which is normal saline or lactate Ringer solution. They just increase your blood volume, and they're actually better because of their availability and their low cost. Then now for this Ringer's lactate, what it does is that the lactate in in the liver that is converted to bicarbonate, so it overcomes that lactic acidosis that was produced in shock. Yeah. Yeah. Then the second one is colloids, which Fatma talked about, was exogenous colloids. So what they're very large. They have a large molecular weight, so they'll stay in the blood vessels and not get. They cannot cross the capillary membrane. So because of that, the concentration of your blood plasma is quite high. So because with the osmotic effect, it will pull blood back into the blood vessel, because we saw that one of the symptoms was that there's the third spacing of fluid. So that fluid in the interstitial space will now get into the blood, increasing the blood volume. Yeah, and then some of the examples would be albumin, hetastarch, pentastarch, plasma protein fraction, which all have a high molecular weight, and because of the osmotic effect, they increase blood volume. Yeah, just side effects for both of them would be fluid overload, dilutional coagulopathy, which is now you're diluting the blood, so so even all the other contents are diluted, like the clotting factors, so it lasts like a bleeding disorder. Then blood products such as packed red blood cells, because everything is now less. Oh, sorry. Yeah, just you give blood products because some of this can be caused by like blood losses from hemorrhage. So you give packed red blood cells, fresh frozen plasma, platelets, precipitate and concentrated coagulation factors to avoid bleeding. Yeah, and then like Gaia said, you give vasopressors like norepinephrine and dobutamine, which can cause arterial vasoconstriction, because one of the causes of shock was vasodilation that we saw in distributive shock. So if you stimulate this alpha-1 adrenergic receptors, you cause vasoconstriction, overcoming the shock. Yeah, so norepinephrine, epinephrine, even, yeah. Dopamine also can be given. And if the patient also has like a concurrent heart failure, then dobutamine can also be added as a vasopressor. And with this vasopressor, you usually start with low doses and then you titrate up to the maximum dose. The adverse effects would be decreased organ perfusion because of the vasoconstriction, and it can also lead to arrhythmias. For hemostatic agents like tranexamic acid can be given when bleeding is one of the major causes for the shock, and of course supportive measures like histamine 2 receptor antagonists or proton pump inhibitors, especially involving the GIT ischemia. Yeah, that is it for shock also. Any questions, clarification, addition?
I have a question, like to the whole group or Hiral. What is the most common cause of shock? Is this or is this hypovolemic due to trauma, or is it the septic shock due to bacteria, due to infectious diseases?
I'm not too sure about that.
I think, guys, it actually
Mhm.
depends. It actually depends on the classification of shock, because like the one for the cardiac shock, it has to do with something that's mechanically happened to the heart.
Mhm.
So like embolism or something of that can lead to arrhythmias or that. And then the other shocks, it can, I think it's due to all either septic shock or a bacteria that had manifested already in there and is trying to decrease the normal flora that are supposed to be in it, helping. I hope you understand. Like because like for the hemorrhagic shock, they say the one of the things that lead to hemorrhagic shock is GI bleeding or a rupture of aneurysm. If that aneurysm was not there, the GI bleeding could either be a natural bleeding due to like all those factors that leads to deficiency of bleeding or all that, or a bacteria that was already in the gut that had led to the GI bleeding. I think, but I'm not sure.
Okay, so I'm seeing that the most common cause for hypovolemic shock is due to blood loss, which can be hemorrhagic or GI bleed or whatever. So just generally blood loss can cause, it's one of the most common causes for hypovolemic shock.
Okay, thanks.
Yeah. Okay, so for the treatments again for shock, first one is crystalloids, where you give normal saline and lactate ringers because you want to increase the blood volume because it's low. Second one is the colloids, which is albumin, hetastarch, pentastarch, dextran, which have high molecular weight. So it's because it produces like an oncotic pressure. So it pulls fluid from the interstitial space into the blood vessel, increasing the blood volume. Second one would be blood products, third one, would be blood products in case of blood loss with packed RBCs, fresh frozen plasma. The fourth one would be vasopressors like norepinephrine, dobutamine, epinephrine, which now constrict the blood vessels because one of the causes for like distributive shock especially was vasodilation. So you need to vasoconstrict these vessels with norepinephrine, dobutamine. Hemostatic agents like tranexamic acid, especially with hemorrhagic shock, and with supportive measures, especially like for GI ischemia, you give this H2 receptor antagonist and proton pump inhibitors. So that's the treatment for shock. And that is it for cardiovascular disorders also. The treatment depends on what kind of shock. Like for distributive, now you would give the vasopressors. For hemorrhagic or hypovolemic, you want to increase the blood volume. You can also give the hemostatic agents. For cardiogenic, depends, like it's because of the, like you talk for cardiogenic and obstructive. Now you look at what's the main cause, what's the underlying cause of that shock, and you treat it like that. So for example, if it's obstructive shock, then where is the obstruction? If it's a clot or it's atherosclerotic plaque, then you treat it according to that. But I think hypovolemic shock is one of the main ones. So yeah. So that
So we
is
call it a day?
yes.
Okay.
So in the afternoon we're starting.
I'll start the renal physiology and anatomy.